Again, my name is Keith Coker. I am an emergency physician at the University of Michigan. I am also the medical director of the Michigan Emergency Department Improvement Collaborative, or we call MEDIC, which is headquartered at the University of Michigan. We're a quality improvement network of about 50 hospitals across the state, working on improving care in the emergency department setting. And we have partnered with the state of Michigan on the Department of Health and Human Services on a project to advocate and implement HIV screening programs in emergency departments in the state, where we've got rising evidence that this is effective and where there's communities that really are in need of this. And as part of that work, we are sponsoring what we're calling a learning series. So a set of talks with rotating expert speakers. We've had a couple to date. We're going to have more in 2025. So please make sure to get on our email listserv, and so you're aware of our upcoming talks. Today we have Dr. Kristen Spoor-Wolf, who is an emergency physician at Hurley Medical Center. I'll let her introduce herself more formally. Just a little bit of some housekeeping. We definitely want to hear questions from you, so please use the chat function to ask questions along the way. We'll monitor that and bring those questions up, and then certainly at the end, we'll have adequate time for questions and answers as well. All right, so Kristen, I think things are ready for you. I'm going to hand off. Take it away.
All right, here we go, everybody. Um, Thank you for having me. I'm Kristen Swar. I'm an emergency physician at Hurley Medical Center, and I'm also the physician champion there for the opt-out HIV screening program. I work with the medic team in the Ending the HIV Epidemic Collaborative, to work with other hospitals to do similar to what we do at Hurley Medical Center. Today, we're going to talk a little bit specifically about the program, opt-out screening program that I have at Hurley, and how we are balancing the public health needs along with the bottom line and all of the workflow and problems that come with starting a new program within a busy hospital system. So a brief introduction to the Ending HIV Epidemic Collaborative, right? I'm not sure who's all been to the prior presentations, but nobody likes to start watching a show mid-season. So let's get everybody caught up. We are a collaborative between MEDIC that Dr. Coker explained in his introduction and the Michigan Department of Health and Human Services. Our goal is to support emergency departments in their development of an opt-out HIV screening program or in any sort of HIV testing that they do. And a couple of quick definitions. Opt-out HIV screening, we are going to break that down. So screening is a test that's not necessarily indicated for the reason that the patient presented to the emergency department. Or screening is a test that's done when the patient may or may not have symptoms. Other screening tests include PSA, cholesterol screening. So, and then opting out is a way of testing in which people are tested unless they decline. The definition proposed by Branson et al. Is that opt-out screening is conducting HIV testing after notifying patients that a test will be conducted and that they can either decline or defer testing. So why do we do this? It's estimated based on 2022 data that 13% of people living with HIV in the US are undiagnosed. And we've noticed over the past 5 to 10 years that additionally, the proportion of people who are newly diagnosed with HIV that have not disclosed any risk factors that we formally and generally think of as risk factors for HIV has risen from 3% about 10 years ago all the way up to 15% in the last Center for Disease and Prevention HIV Incidence and Prevalence report. Another reason we do this is we're trying to destigmatize HIV and its testing. Having an opt-out screening and normalizing it will allow the patient or the person to accept testing and to hear it as a thing that is done by everyone, if they're told that they're going to be tested for something rather than, do you want this test? They don't have to go through in their mind, unconsciously or consciously, do I have risk factors? Am I that person? Could I have HIV? And all of the other background biases that come with or have come in the past with HIV and AIDS. And the other reason we do this is to ensure that the health systems that we're working with know how patients with positive screening tests are able to receive reliable follow-up. My role at both with Medic and at Hurley Medical Center is as a physician champion. Now, there's nothing special about the physician role. It can be anyone who's passionate about HIV testing in your health center, a physician, a PA, a nurse practitioner, a nurse. That person's role is to oversee HIV opt-out screening in the emergency department, to work with the health department HIV liaison, to notify them about any positive screens and expedite testing. And then further duties vary, but can include facilitating downstream testing for additional infectious diseases and blood work, liaising with your local ID clinic, and continuing with staff education to keep the program running. Today, like I said, we're going to talk about specifically the opt-out HIV screening program at Hurley Medical Center. It's going to tell you how this is done at my particular facility, but every healthcare system is different, every emergency department is different, and there's many, many ways to skin this cat. So we'll talk a little bit about the program initiation. We'll review the personnel that are involved in our HIV screening program, describe the systems that are involved, talk about workflow, talk about financial feasibility, and a brief demonstration of outcomes. To the right on your screen, you will see a notice. This is a variation of the testing posters that we have in all of our triage room and in all of our patient care room that notify our patients that we perform HIV testing. Hurley Medical Center is a 430-some bed public nonprofit teaching hospital in Flint, Michigan. We're a level 1 trauma burn center and a children's hospital. And we're a 75 bed plus how many hallways and chairs can you squeeze in patient emergency adult and pediatric emergency department. We are north of 80,000 visits annually, and our patient catchment includes a significant number of uninsured, uninsured, and publicly insured patients. The last data that we have on HIV prevalence in our county, which is Genesee County, is about 0.17%. So this started with much credit to Nicholas Rademacher, if you're out there, a physician colleague who began a collaboration in 2018 with the infectious disease department and the emergency department to start an opt-out HIV screening program. It started by reviewing current testing practices in the emergency department, which frankly were very variable. Some people didn't test for HIV at all, no matter what. Others only tested if it seemed that someone had an AIDS-defining illness or they were suspicious of HIV for another reason, whereas other people would test if they were testing for STIs or would test more routinely. And also review of the current language of HIV testing laws. That's the Michigan Compiled Law Section 333 that we'll get to in the next slide. But that was an important part of getting everybody on the same page about HIV testing in an opt-out manner. There were EMR, electronic medical record, and emergency department workflows that were designed, approved, and improved. And we also received a grant from the Wellness Aid Services for the first 2,000 tests that we performed in 3 months. So this is a nonprofit, community-based organization in Flint supporting people in the counties listed below who are affected by or living with HIV. I think in your chat, you will see a link to this particular law. This is just a screenshot. As many people who have been practicing or in the world of medicine for more than the past 10 years or so would know, HIV testing used to be fraught with a lot of stigma, paperwork, and special requirements. In order to test for HIV, you needed to consent the patient on a formal separate consent sheet. Additionally, you had to be capable of providing appropriate counseling should the test be positive and appropriate follow-up. And many places shirked from HIV testing because they were unable to provide that adequately or feared they were unable to do so. As you can see, this act was written in 1978 and it has been revised many times. I'd like to read out loud for everyone the current important parts of it that reassure all of you that HIV testing in an opt-out format is absolutely a doable thing, both from a legal and a medical standpoint. So if you look at paragraph 2, I'm going to paraphrase here. A patient or patient representative who provides general informed consent for medical care is considered to have consented for an HIV test. A separate consent form for an HIV test is not required. You do, however, have to inform the patient or their legally authorized representative, either verbally or in writing, that an HIV test will be performed unless the patient opts out or declines, and offer the patient or the representative an opportunity to ask questions and decline the test. And if we skip backward just a little bit to the to the slide with our routine testing, this is part of our notification and information to our patients that they can decline testing and that is opt out. The link to this particular public health code should be in your chat now. So going on to how we made this work, we actually launched HIV opt-out screening in our emergency department in 2019. It was a busy year for all of us in healthcare, but it was launched essentially with an EMR workflow and a lot of education to our nursing and physician staff, but not a lot of additional work outside of the emergency department current workflow. So in the emergency department, patients were informed of the program, they were tested, and notices were posted about the emergency department. In triage, all patients between the ages of 18 and 64 without an HIV test in the past 12 months or who weren't already diagnosed with HIV were notified that they would be tested for HIV unless they opted out and were given the opportunity to ask questions during the triage questionnaires. If the person did not opt out, then in the patient's chart, we have Epic for our electronic medical record. Best practice advisory, which was not a hard stop, would pop up when a patient's chart was opened by the physician or the PA, stating that the patient was eligible for an HIV and asking the physician to order the test. In the background, the physician champion received a report generated daily of all of the HIV screening that was done in the emergency department. And then mostly by the Genesee County Health Department, but occasionally in the emergency department, the disclosure of positive screens occurred. And then as an outpatient, follow-up testing was ensured and follow-up treatment. As far as our workflow, getting down to the nitty-gritty, which is how long is the patient going to have to be there? How much more work will this be for me? The increase in ED dwell time was essentially no minutes. The patient leaves when the treatment is complete, and the testing for the reason they came to the emergency department is complete. You could argue that if venipuncture wasn't initially planned, that this could slightly increase the patient's dwell time. But oftentimes in our emergency department, when a patient arrives and is roomed, it's common for a nurse or a tech to draw a rainbow lab or several blood vials and set them aside should they be needed. This opt-out screening made it easier for indicated testing, such as when patient comes in for an STI check, and the general practice was to just test for gonorrhea and chlamydia, and now like patients already consented for HIV, so the blood is there. In the lab, we have a median turnaround time of about 98 minutes for our HIV screening, provided that the lab, given not taking into account, hospital volume and emergency department volume. To the right, you're going to see the triage questionnaire that comes up in any patient between the ages of 18 and 64 who has not had a test in the past 12 months. You can see that this is already scripted in the green just below ED HIV screening. So the nursing staff doesn't have to learn anything new and doesn't have to be specially trained in any HIV screening counseling. You can see it says at Hurley Medical Center, we test all qualifying patients for HIV unless you say no. And then there's a hot button that clicks to whether the patient is authorizing opt-out testing or declines or doesn't have the capacity to test. And then when that window is closed and the patient has assented to testing or has not declined, the best practice advisory will pop up when the physician or the PA opens the chart. A little bit of a snarky slide here. This is a list of all of the extra hired staff and all of the additional FTEs that were rededicated for this project. Now, that doesn't say that the emergency physicians and the ID docs who created the program didn't take a lot of time, energy, and effort into their program, but really this is a workflow that's fully integrated into our EMR. The education was integrated into our staff meetings, into our nursing huddles in 6 minutes, and so there was little extra time outside of the regular flow and work of the emergency department that was required to get this project up and running. So we're going to go on to the workflow, I guess another goofy slide. If The screen for HIV was negative once it was ordered. Then you were done. Those results post on the patient's Epic on hand or their My Chart, but no extra notification is done. Just like you wouldn't have notified someone that their CBC, their basic, any other test that they had done was negative, with the exception of all of your tests were negative. So there's no particular notification of a negative HIV screen in the emergency department. Moving on, if there was a positive screen from an emergency department blood draw for HIV, um, if the patient was discharged, an important thing to recognize here is the emergency physician isn't responsible for notification of those results. If the patient is gone, then the emergency physician who ordered the test, their responsibility for following up on the test is gone and is taken over by the program that we have. If the patient is present, the patient is then notified by the emergency physician, and oftentimes during office hours, they were also referred to ID, and the infectious disease doctor may not come and see the patient, but certainly would facilitate a rapid outpatient ID appointment. Passively, a confirmatory study for any positive screen is automatically added to the blood in the laboratory to confirm that the HIV screen was in fact a true positive. We're not going to get into the nuts and bolts of HIV screening and confirmatory testing here, but this is done automatically in our lab and was done prior to our HIV opt-out testing. And I would suspect that anyone else's health program also health system also has confirmatory studies that are done automatically rather than by human recognition and manual ordering. And then in the background, the physician champion would notify that it notifies the health department HIV liaison of any positive screening tests. This slide will tell you a little bit about my role as a physician champion. So I do serve as a liaison to the health department, and I verbally, by phone or by email, will talk to the disease intervention specialist. If you're out there, Ms. Woodson, thank you for all you do, about any positive HIV testing. I'll follow for any confirmatory tests. And in our particular program, I'm the one responsible for placing outpatient orders for the additional blood work needed for someone who's newly diagnosed with HIV. I also confirm with the health department that they've been able to contact the patient, which is important when there's difficulty getting in touch with the patient. We've set up in the past people that have been unable to be contacted. We've set up pop-ups within our electronic medical record so that when the patient returns again and their health record is accessed, there's a notification to whomever opens the screen saying this patient needs notification for their HIV testing, and to allow that to happen face to face in the emergency department or the outpatient setting if the patient couldn't be found by the health department. And I also will alert the infectious disease clinic about a patient who may need expedited appointments. To the left, you're going to see excerpts from emails I get each day. So this is again an automated setup through Epic. Every time an HIV screen is performed in the emergency department, it's added to a list that's compiled. And every 24 hours, I receive an email. Up top is an email that I receive when there's no positive testing. So you can see there's a summary of 4 people being screened for HIV, all of whom were negative. Below is an example of an email received each 24-hour period for someone who has a positive test. You see there's an additional column there. And below are listed, but of course blocked out because it's PHI, are the name, date of birth, and medical records so that that person's chart can be easily pulled up by myself and then referred with the following steps. So when the health department finds out about a positive screen or a positive confirmatory test, the health department liaison, the disease intervention specialist, actually finds the patient and discloses the results face to face. They are the specialists that we are not in counseling the patient about a positive HIV screen or a positive HIV test and diagnosis. They provide assistance with partner notification, link to care, and in some circumstances, we'll even go out to the patient and draw confirmatory blood tests if for any reason the blood tests were not able to be performed or were insufficient for the diagnosis of HIV. Depending on where you practice medicine, this could be the Michigan Department of Health and Human Services, this could be your local city health department or your county health department. And so that's a brief overview of all of the workflow in the system that it takes to do HIV screening at Hurley Medical Center. But I wanted to take a brief aside because I know that not everybody here is going to be able to launch a formal opt-out HIV screening program. And I know that a lot of people are getting it launched and wondering, well, what can I do in the meantime if I want to continue or start testing screening for HIV in the emergency department? Well, I want to assure you all that the health department has got our backs. Um, if you have no formal system in your emergency department, no physician champion that calls the health department, they're going to find out anyway. HIV is a reportable disease. Your lab has a mechanism for reporting this, I promise. The Michigan Disease Surveillance System is the way by which reportable diseases are entered into the state of Michigan database. And anyone who has got a functioning licensed lab is required to report these diseases and have a system in place. So once once there's a positive screen and the lab reports, the your local health department disease intervention specialist takes over. So you see this and you may think, well, then why bother having a physician champion? Well, we have this automated system and all of us do, but it's really good to expedite the workup and to have a personal connection through the health system and with the health department. To your right, you're going to see a flyer from the Michigan Department of Health and Human Services. And in your chat, there's a link to the PDF for this. This is the Michigan Department of Health and Human Services. You test, we do the rest. Outreach for both HIV and syphilis. It basically says everything that I just talked about, but we're going to highlight a couple of things. As I've said, labs are required by law to report any positive results with the state and local health departments. Case reporting has to be submitted. So your lab is already doing this. And all new HIV cases are assigned a disease intervention specialist to ensure reporting, follow-up, disclosure. And the disease intervention specialist help patients with the new diagnosis, share history, discuss treatment, help patients get treatment, and make sure they understand the testing regimen. Um, so we'll go back to our workflow. I want to talk a little bit about the cost of HIV testing. I'll be honest, this is not going to be the testing program that makes your health system $1 million, but really what is. What I want to show to you is that HIV testing is also a program that is not going to break the bank and is not going to cost your health system anything. Based on information from our lab, the cost of an HIV test at Hurley Medical Center, including reagent, quality control, and tech time, is about $20. We bill $49 to all insurance companies and are reimbursed between $13 and $26, depending on whether this is a public or private payer arrangement. On average, we get about $21.15 back. It's probably a little bit lower than that because we have a higher public payer mix. And I'd like to also share with you our results. So this is really where the meat of the program is, and I'd like to share our success with you. As I told you before, we did receive a grant, and we were able to receive that full grant amount. In our first 3 months of HIV opt-out screening, we tested more than 3,000 people. To date, we've tested 17,401 people, although I don't have the data just from yesterday, from the emergency department. And of the people who've had a positive screen, there have been exactly 0 that we or the health department have not been able to get in touch with. I'm going to say that again. Every single person with a positive screen has had face-to-face disclosure of their results, and they have been able to have their confirmatory and follow-up testing and treatment successfully linked in with either our infectious disease clinic or with any other infectious disease or HIV clinic of their choice. We've identified more than 40 people with HIV. Some of these people are people who are new HIV diagnoses, but there's about 4 to 6 of these people who have had HIV and have fallen out of the system. Either we're not getting treatment because they moved somewhere else, or their comorbidities or mental illness had kept them from recognizing and sharing their HIV status with their health providers, and we've been able to link those people back into their system. And for those of you who are bottom line people, we've had no denials from insurance companies for reimbursement. More importantly, HIV screening in our emergency department is now a normal background activity. It's not an additional thing that we do. It's not an additional workflow. It's just part of everything we do, just like signing on to the patient or going through triage, screening about domestic violence, or ordering the next CBC. It hasn't added too much extra work, and everyone has uh, incorporated HIV screening into their practice. So, in summary, opt-out HIV screening is important because it diagnoses people who were prior unrecognized with HIV and it links them to care. It decreases the stigma around HIV, AIDS, and the testing for it, and thus increases people's willingness to be tested and then eventually identified and treated for a very treatable disease. It can be implemented with minimal impact on emergency department flow. It is reimbursed, in my case, 100% by public and private health insurance companies, and is financially feasible. I'd like to thank a lot of people. First of all, Nick Rademacher, who launched this program, and the many people from both Hurley Medical Center, the Department of Emergency Medicine, the Health Department, and Medic for making this possible. And I can take any questions now.
Kristen, that was so awesome to hear about the success of your program. Yeah, we definitely want to take some questions. Again, you can use the chat function, come off mute. Definitely have a thumbs up from Katie about the great presentation, Kristen,
Oh, thank you.
and others I'm seeing here too.
And I do want everybody to see up in the chat both the legislative law that gives the details on the permissibility of HIV testing without additional paperwork or counseling, and the You Test We Do the Rest PDF are in the chat.
Um, Sam, I don't know if you want to respond to this question about sharing slides.
Yeah, absolutely. Dr. Swar was gracious enough to share these with us and gave us permission as well to send them out. So when we get the video recording up and running on our website, I will send a follow-up email that'll have the slides, the link to the recording, our past recordings, and an invitation to the next series. So I will make sure in the near future to get the slides and the recording to you guys.
Kristen, I definitely have a question, and we're waiting for others to try. Oh, actually, yeah, hands up. So Nick, I see.
Yeah, I'm a ER doc in Grand Rapids at
Great.
Corwell Butterworth. I'm curious about whether the opt-out screening with anyone with a blood draw is meeting kind of the CDC's threshold for positivity for a screening initiative of like trying to shoot for, I think is what, more than 0.05% positive or something like that. And the way we've implemented screening here, it's been targeted on people that are getting STI testing, and then we ask them to also do a blood draw and get their HIV testing. So it's just a different technique, and we started with we felt like a higher risk population to try to get that positivity rate up to make the screening investment feel worth it. But do you still feel like it's kind of meeting those like the thresholds of when universal screening is the right investment when you do it as opt-out blood draw or for anyone getting a blood draw?
So with our background rate of HIV in Genesee County, and arguably with the background rate of HIV in Michigan or within the US, opt-out screening is really indicated pretty much everywhere. I mean, you can get down to granular populations, but yes, I do think that we are meeting that. And also, is a bit of semantics, but when you're drawing for HIV and syphilis, when you're doing STI testing, that's actually more of an indicated testing than it is a screening. And I'm excited to hear that your program is doing that because
Right.
arguably anyone who's getting a test for gonorrhea or chlamydia, these diseases are all transmitted sexually. And so if you're at risk for one, then you're at risk for the other. And it's great to hear that your health system is doing those tests.
Yeah, that's where we kind of started by kind of asking people to also get this test every time if they hadn't got it in the last year. But yeah, I
Absolutely.
guess that makes more sense that it's sort of targeted testing versus universal screening. Thank you.
Did I answer your question about the appropriateness?
I think so. Yeah, 17,000 tests and 40 positives. I mean, that's that's 40 patients that now are not spreading illness and are getting connected to care. And um, I see the value. Yeah.
And I will tell you, the percentage is low. That's 0.03, or that's 0.3%, which is not, or 0.003%, which is much lower than our disease prevalence rate.
Right.
And it's kind of an interesting thing is I don't know why our opt-out screening is lower if we're happening to see a population in the emergency department that is lower risk, which would be very strange, or if we just, many of these people are already identified and coming to the emergency department. But those particular people's lives have been improved.
Yeah, of course. Thank you.
Keith, it looks like you've got a great link that you posted about best evidence for HIV screening in the emergency department for targeted and non-targeted testing.
Yeah, I mean, we don't need to get into like a deep dive on the evidence here. But it is, I think, rapidly evolving. And I think this is an example where, this is like a randomized control trial, sort of testing different approaches, trying to get at this exact question that you raised, Nick. So it's probably worth reading.
So I see a question in the chat about how often patients opt out. I think that question is really variable. When we began the program, we were testing 20, 30, 40 people a day. In a hospital, we have probably like 200 to plus visits a day. Many of those were either pediatric people under 18 or over 64. And over the course of our testing, we have had fewer tests done per day. Oftentimes that number comes back up when we remind everybody, hey, this program exists, don't forget to do it. But also, I think that we've tested a lot of people, and many of them don't actually qualify for retesting or believe that since they've already had the test in the past 4 years, even though they're eligible for every 12 months, they don't necessarily get the test.
Kristen, I think we got another question here. Hands up. I think Brianna, is it?
Yes, it is. Hello. Thank you for your presentation. I found it very interesting. My name is Brianna. I'm a nurse practitioner at the Detroit STD Clinic and also a member of Michigan Maytech. And my question, I was just curious. I know in a portion of your talk, you mentioned that a lot of times patients were notified by DIS, that face-to-face contact. For those providers and physicians that did disclose that person's positive test result in the ER setting, did those providers provide any information about their experience with that? Like I can imagine a person comes in for runny nose or a broken arm or something of that sort and receive that information. And I was just curious if there were any physician perspectives that you collected data on in that regard.
I've collected anecdotes. I don't think I have data. We're a pretty small physician group, and so we hear about things when it's a little bit out of the ordinary. And indeed, it's out of the ordinary. We have a pretty low rate of positive screens. So when an HIV test does come positive while the patient is still in the emergency department, I generally get an email because they know that that's me. And their experience is probably a mix of just this is what I did, and a little bit of, oh my gosh, this was such a surprise.
Mm.
Most people during business hours, will contact the infectious disease clinic, and they will get that person. Most of them, I would say, would contact the infectious disease doctor and say, hey, I have this patient, they've screened positive. How do you want me to get their follow-up? And our infectious disease group is very much on board with this program and will come down and see the patient if they're able, and if not, we'll set them up as an outpatient and we'll provide them any resources.
Great, thank you.
You're welcome.
Kristen, I have a question for you. I bet there could be some folks on the audience here who are infectious disease. And I'm curious, how what that relationship is like locally. You mentioned that a few times, but also I don't know if you can speak to other models for follow-up that we know might have been employed in other ED settings too.
Absolutely. And I welcome any questions about other settings or other variations in this, because Hurley Medical Center is just one way to do this. In our county, I think we have an infectious disease clinic that does have an HIV clinic. And patients who have a positive screen, I would say about 2/3 of them have chosen to follow up in our clinic initially. There's also the Ryan White Clinic and Rainbow Clinic and a couple other HIV programs that are within the county or nearby. And what happens generally is that the disease intervention specialist at the health department gives the patient the choice. Whether the patient chooses to come to Hurley or not, I will generally put them in as an expected lab draw so that they can easily come back and get additional follow-up testing like CD4 count and basic lab work, whether they choose to follow up with us or not. I know that at Henry Ford, the most of the follow-up is internal, where close to 100% of the patients who are screened as positive and found to have HIV do follow up in their infectious disease clinic, and they have a tight relationship with their emergency department.
Kristen, there's another question that was in the chat that I missed around how often in your program do patients end up opting out of HIV screening? I don't know if you have any information or sense of that.
I don't have a number. We see trends. When we started testing, the numbers were, in the 20s or the 30s, and they've decreased now to like the single digits or the teens, and they kind of bump up as we put reminders out. But I don't know exactly how many people opt out or what percentage, and that would be a good thing for me to look forward to and find out.
We definitely have more time here for questions.
Is there anyone else who has opt-out HIV screening or a policy of routine HIV screening in their emergency department?
I know currently in Missouri, we are trying to implement rapid HIV testing throughout our 37 counties that my specific health department has jurisdiction over.
Mhm.
And so that's something new that we're looking forward to.
That's fantastic. Now, we don't actually use the rapid HIV testing because it's more expensive, but we accepted that our turnaround time and the backups, the systems we have in place were sufficient for someone who had a positive screen but was not going to be in the emergency department. Again,
Yes,
lots of ways to skin a cat, many ways to do this. Yes?
I was just going to say it's nice to see, different implementations and even, right now, like the rapid test will be covered via a grant, but, moving forward in case that grant isn't still able to be, for the longevity, it's nice to see that you guys are still able to do it without that.
Absolutely. And I know that Henry Ford, their opt-out screening is anyone who has a CBC rather than anyone. That way, they're certainly not adding additional ED wait time for people who may leave and not necessarily get their blood drawn.
This is Bethany Foster from Detroit. I'm at Wayne State University and I'm at the DMC facilities, and we actually do a rapid testing program just because we haven't been able to get our parent company to jump on board the routine testing train. But if you have any questions about rapid testing in EDs, I'd be willing to talk with you.
That's fantastic. Do you test everybody who comes in who consents, or do you have a certain population that you look to?
We offer it to anybody that would like it. We do prioritize those that are coming in for STIs, new pregnancies, or if like a provider is requesting it. But we really don't. Whoever would like it, we would provide it.
You said you were located where again? I'm sorry.
Detroit Medical Center at Wayne State University. We have three hospitals that we do it in their emergency departments.
Kristen, looks like we have another hand up from Nick again. So Nick.
Yeah, just like as I think about this, another question comes to mind. The additional testing load in the lab. How did you get your lab colleagues to kind of agree to it? I understand that you saw that it was cost neutral which is very encouraging. But if I'm asking our lab to run all these tests, and are they going to say, well, that means we're going to be a little slower on everything else because there's just more work for us to do. Did you have any of that pushback, or did it add a burden to your lab to run all these tests?
That's a great question. As I was not the one that started and launched the program, I can't speak to, if there was any pushback from the lab. Whatever there was not insurmountable because here we are.
Yeah,
And really, in the end, in a big hospital system, even on the days where we're doing 20 additional tests, with all of the cartridges that there are, it's not that much more than what we're already doing.
sure.
It
Yeah, I'll have to
probably
ask.
helped that we were in the middle of a global pandemic when it started, so there were, no patients anyway.
Right,
So those
right.
extra tests didn't bring it even back up to our baseline population. And then by the time the pandemic was over, it was just sort of integrated into the hospital. Thank goodness for COVID.
And in your experience, it doesn't require like a separate tube being drawn and sent to the lab. It's just the
Nope.
same one that you're already sending for the CBC or something like that.
CBC, yeah.
Yeah. Maybe it's all just automated on their side. I'll have to check with our lab colleagues. Thank you.
Yep, and I can find out more. Our lab is fairly automated, but if you want me to get more granular details, I'm more than happy to find out for you.
Yeah, if it becomes a barrier, I might follow up with your experience, but it's good to
Of
know that it
course.
didn't seem like an issue for your system.
Another thing that I want to note too is how customizable this kind of thing is. As Dr. Swor mentioned, the other program that we have kind of looked at a little bit more closely um, at Henry Ford is that they only do it with a CBC that's already being ordered. Where like at Hurley they do it for everyone. So like if we're looking at lab volume and things like that, that's one of those things that we can like customize, or we can definitely like talk about how this could look different at different agencies. And I want to offer this to everyone on the call. Of course, if you have questions or want to brainstorm more, like reach out to us about like what this could look like or potentially could look like at your agency, kind of like roadblocks that you might foresee. Like we are here for that. We're here to just kind of brainstorm and talk through those ideas with you, even just as an initial conversation. And you also had mentioned so maybe statistics and prevalence rates and what that could look like. Our partners at the state have been incredibly supportive in getting us data for sites that are like, is this right for us? Is this something that we should be looking at based on our region? And like, we are more than happy to help coordinate and get you some of that information too. So, yeah, just putting a little bit of a plug out there for what we're willing to do to support sites that are wanting to continue this conversation on a little bit more of a granular level.
See, it looks like Caitlin, you have a question?
I just wanted to say, going back off of Nick's question, with, kind of lab pushback, in some of the conversations I know that I've heard not only, maybe lab pushback, but also even IT pushback as far as implementing it. I'm assuming maybe you haven't had some of those barriers, but particularly one with a hospital that uses Meditech, which I guess is not an EMR system that is, let's say, universally used as much.
Mhm. Um, so the programs that I'm most familiar with, which are mine and Ford, both use Epic. And we have an Epic team whose job it is to, make Epic work and to make all of the order sets. So part of what they do is they take any new ideas, workflows, and they develop them and launch them. And that was part of a role that already existed for someone, and it was part of their job already. I can't really speak to other electronic medical records. But I'm sure that the problems are not insurmountable. And I would be happy to brainstorm with you based on how your EMR works, how to pull that testing. Bethany?
I did have a question regarding the reimbursement, which is great to see those numbers so that I can
Mm-hmm.
try to present that to our leadership.
Mm-hmm.
I think that it's the bottom line. But were you having any problems with reimbursement for people that got tested multiple times within a year? Because we do have people that sometimes come every 3 months, and I don't know if their insurance would um uh would reimburse that many times.
Gotcha. Well, the answer is no, since we have not had anyone deny reimbursement. But additionally, our the nursing screen and triage, that question is only triggered in people who are between the ages of 18 and 64 and do not have a prior diagnosis of HIV or who have not had a test in the past 12 months. So theoretically, if someone comes in every 3 weeks or every week, that question should not pop up in their nursing triage assessment.
Okay, thank you.
You're welcome.
We certainly have a few more minutes if there are any other questions. If not, why don't we wrap up? I want to thank Dr. Swore-Wolf for giving us, really, I think sounds like important information for all of you on the line here, understanding, what are the nuts and bolts of developing and sustaining a program like this. And definitely, I was hearing some voices from emergency departments across the state. Look, this is a learning series, but in parallel, we are actually also separately supporting implementation of these programs in emergency departments just like yours. And we'd love to partner. We have resources. We have help from the state. We even have some grant money that could facilitate local implementation that we could help you get to. So please reach out to us. Sam Kesterson is the project manager for this work. She just put her email in. Kristen's one of our leads on this project. Her email's in there. Please reach out. In fact, we may reach out to you. Additionally, make sure that you complete the survey. I mentioned this at the beginning. There's the QR code, short survey just for us to have a little bit of some information about, again, your sense of this work. Remember too that you can claim CME credit for this. We'll give you some information about how to do that in the follow-up email from Sam. We use the University of Michigan. I'll just note that they have this 7-day limit. So just make sure you claim it within a week to get your credit. And then finally, as I mentioned earlier, this is an ongoing learning series. So we will have several other speaking events in 2025. And the next one is Jen Miller. She is the state's epidemiologist. And we'll be talking about the epidemiology of HIV, hepatitis C, and syphilis in the state of Michigan. So please mark your calendars for that. Make sure you're on the listserv. And, it was really wonderful to have such a great audience. Thank you so much for your attention. Appreciate all your time.